Good evening, and thank you for the invitation. It's my second visit to Angola in the last 6 months, and I always enjoy coming. The people are very warm and friendly here, and I've developed a lot of good friends. It's always a pleasure to be here. I come from Orlando, Florida, and my specialty is urology, and in specific robotic surgery and for prostate and kidney cancer. So these are the things I'll be talking about. I'll talk about some of the new types of surgery that we're performing and some of the things that are happening in the future, which I think will be very interesting for you. Prostate cancer is relatively common in the U.S. As you can see, about 230,000 people are diagnosed every year, and about 30,000 people die from the disease. So prostate cancer is pretty common. It's the second leading cause of death in men in the United States. And so obviously, it's one of the key issues in healthcare for us in the United States. When you look around the world, the incidence of prostate cancer really is quite varied. As you can see in Asia, it's not so common. That may be related to the fact that screening is not so common, whereas in the United States, Europe, Australia, the places where screening is more prevalent, obviously the diagnosis of cancer is also the most prevalent, so this is where you see it. And you see in Africa, it's really relatively intermediate in terms of the diagnoses. Most people are getting prostate cancer later on in life, usually 65, 70, but I can tell you my population continues to get younger and younger, and so we do see men in their 30s and men in their 40s, especially African American males who get prostate cancer. We know from the studies that African American males tend to get cancer of the prostate earlier and more aggressively and are more likely to die of it. And so those are the patient populations that we keep an extra eye on. For those of you who aren't into the field of urology, this is the anatomy showing the kidneys up top emptying into the bladder, and there in yellow is the prostate. And this is the challenge. We're trying to take an organ out that is very deep down in the pelvis, removing it from the bladder and unattaching it from the urethra. So this can be quite a challenge. And when we did surgery the old way, with open surgery, these patients used to have quite a bit of comorbidity. They used to often stay in the hospital many days. They often lost 1 or 2 liters of blood and required a transfusion. Now it's very different. The patients have about a 1 or a 2 hour surgery. They don't require transfusion and they go home the next day. So with robotics, we've advanced quite significantly, and I'll show you why. So these are the different stages of prostate cancer. Obviously, it can go from something relatively small all the way to stage 4, where it's invading into other organs and maybe even metastatic. This is what the organ looks like. You can see it looks at the shape of a walnut, very fleshy, but it can be quite large as well. It can be also the size of a grapefruit. So the prostate sizes are very variable, and each surgery is definitely quite different. All prostate cancers are not the same. All prostate cancers don't need to be treated. It often depends upon the patient's age when they get the diagnosis, their health at the time of diagnosis, and also the aggressiveness of the cancer. And so as you can see, there are many, many different treatment options, and we really have to individualize the option for the patient. I really think the key to the prostate cancer is finding the cancer. There's a lot of controversy right now in the United States about who should be screened, who should not be screened. I think the key is we should offer all men the right to know if they have cancer. So I think if it comes to screening, I would vote for to screen, but then leave it up to the patient if they have cancer to decide if they want treatment or not. And the 2 ways to screen really are digital rectal exam, where you put a finger in the rectum and try to feel the prostate, and you also have to check the blood for PSA, the prostate-specific antigen. So PSA is a screening test, and as we know from the New England Journal of Medicine articles, the 2 together are very important. PSA alone or examining the prostate alone are not good enough. You have to do both. The PSA is a basic test that many men have just during their routine physicals in the United States. And the labs vary. The values are quite low in patients that don't have cancer, often less than 4, and high in patients who do have cancer. However, there are exceptions. Some of the more aggressive cancers do have low PSAs, and that's why you can't rely on the blood test alone. So there's no single value, and that's what makes interpretation of these blood tests very hard. There's no single value that represents cancer or no cancer. So you really have to have some education and also examine and speak to the patient about their history. Once we have an elevated PSA or we find a nodule on our rectal exam, the diagnosis stage starts. And the only way really to diagnose prostate cancer is based on biopsy. Ultrasound is one of the most common ways of diagnosis here. And what you can see is one of the newer technologies that really is in Europe. It's not even readily available yet in the United States, but we did the studies with something called histoscanning. And this is a very unique type of ultrasound. It's really a regular ultrasound, but they actually take different signals from the ultrasound. And as you can see here, in real time, this is us doing this case. We're mapping this prostate under ultrasound guidance. We're measuring its size, and then we'll get a three-dimensional visualization of the prostate, and then the ultrasound signal is taken, and the algorithms show where the larger volumes of tumor are. This is a very important thing for us. As surgeons, we have an idea where the cancer is. We know where the prostate is, but we really don't know the distribution of the cancer, how it looks. Now, with potentially histoscanning, we may well be able to tell. As you see here, this is us performing a 45-second scan. It's very quick, and there in red you start to see where the main volumes of cancer are. And down to the bottom right, you can see the elevated, enlarged 3D image of the prostate and the areas of cancer. So these are very important for us. As a surgeon, not only do you want to know where the organ is, you also want to know where the cancers are and how they look. So I think this is a nice breakthrough in technology, and this is really what I'll present today. Some of the new things coming out that can help cancer surgeons, not just for prostate, but also breast, thyroid, even for ENT tumors. Obviously, once the biopsy is performed, the pathologist has to decide if it's cancer or no cancer. And then once that happens, the patient has a choice. Older patients, sometimes we do nothing. Relatively older patients, maybe 70, 75, we can offer them surgery or radiation. But young patients usually go to surgery in the United States because what we do has to last for 30, 40, or 50 years if they're very young males in their 40s or 50s. So the long-term definitive care of a patient, long-term cure, is usually removal, radical prostatectomy. And now 90% of all of the cases in the United States are done using a robot. And I'll show you how this robot works and how the prostate comes out. So we were in the New York Times about 18 months ago, and it was really when robotics really took a foothold. At that time, about 85% of all the cases in the United States were done robotically. As you can see, I sit at a console. I'm actually not next to the patient. I'm actually not even in the same room as the patient. I always operate in a separate room, and it's much nicer. I get to sit down, it's much quieter, and I can concentrate better. So I'll do 7, 8 prostatectomies a day. I did 7 yesterday before we got on the flight to come here. So this has become an operation that is relatively common. We have the largest experience in the world. Now about 5,000 of these cases we've performed. But a robot is not like you would see in the movies. It's not automatic, it's not automated, it's not like how cars are made. These kinds of robots are controlled by humans. So basically, it's a type of relationship where the surgeon controls the robot and the robot does what the surgeon tells it to. Basically, it provides me with better eyes because I have 3D vision, and it provides me with better hands because the instruments are very, very small, and they can crawl into the smallest space and do what my hand cannot do because I wouldn't be able to see. So this is really the advantage of robotics. It's in 3D. You see it just like you would be looking at something directly in front of you. It's not two-dimensional like a television. These are the instruments. They're about 0.5 centimeter to 8 millimeters in size. Very, very small. However, because I have 10x magnified vision, they look quite large. And this is how we are. You know, the robot is there, it's draped, it's over the patient, there's an assistant at the bedside, and I sit at the console, much more comfortable. This is how we control the robotic instruments. I put my fingers in these little holders. When I turn my wrists, the instruments turn. When I open my fingers, the instrument's open. So the robot does everything exactly in real time. So you cannot tell whether it's your fingers or the robot. And especially now, after many thousands of cases, it feels like just my fingers are doing the operation just like I did it with open surgery. So after a while, you can't tell the difference. So here's the video. There's a patient there lying down. He's got these little ports. You can see these little tubes coming out of the abdomen. That big thing there is the robot. It's actually quite large. It's probably about a ton in weight. And what we do is we attach the robot to the ports, which are little tubes that go into the abdomen. And then we put the instruments through there, and the robot instruments are controlled by the console where I'm sitting. So here we're attaching the robot. You'll soon see the instruments go in, and in the next video I'll show you how the instruments work. So there. The robot has about 4 arms. So as a surgeon, now you have 4 arms to control instead of 2. So it's very interesting to be able to control all these arms and the vision all at the same time. So it takes some practice. It does take some experience. And there's the camera going in, and you see the instrument. So that's the robot in use. So inside, this structure down at the bottom of the screen is the prostate. This is the big veins that go into the prostate, and we're using the robot with a needle and a thread to actually tie off the veins so that the patient doesn't bleed. When we did open surgery the old way, with a big incision, with our own hands, this is where we used to lose a liter of blood, because we could not see these veins. They were so deep under the pubic bone, it was very difficult. Robotically, as you see, very, very easy to see. We can manipulate everything with the robotic instruments. It's just like using your own hands, and you tie, you cut, you sew, everything with these instruments. And it's much faster than it was with my own hands, and definitely much nicer for the patient, because they have less blood loss. They go home the next day, and you see here, we're just tying the knot to make everything come together. So this is tying off the dorsal vein. But you can do everything with this robot that you really could do with your own hands. So this is what we're showing here. Here's another video. It's basically showing some of the dissection capabilities of the robot. You see I have 4 arms that I'm controlling, and we have scissors, we have devices that deliver heat, and we have assistants that can place clips. And so that's the prostate being held. And you can see with the scissors, you use them like a little paintbrush. These instruments are about 5 to 8 millimeters in size, very, very small. We could not do this when we did open surgery. We could not see this anatomy very well. But now with robotics, as you can see, we can wrap the tissue, we can spread the tissue, and we can also dissect and clip the tissue. So here we're isolating the main artery that goes into the prostate, and my assistant will come in now and they'll actually put a clip from the outside. So much easier to do surgery in confined spaces, much less bloody, and much easier for the patient to do. Outcome-wise, these patients do very well. Their chance of getting their cancer cured, the chance of getting their continence and their sexual function back is very, very good robotically, as long as they're like that before, and they have a surgeon that is experienced. So in robotic surgery, definitely experience is the key to the outcome. The more you do, the better the patient does. So here you can see, at 18 months, 91% of the patients completely recovered, and we're almost back to normal in terms of their health and their recovery. So very different from how it was when we did surgery the old way. What's in the future for prostate cancer and also for surgery in general? It's very interesting. About 6 months ago, we received a $4.2 million grant from the U.S. government, and they asked us to work on futuristic things like telesurgery. You saw Dr. Claudia Lautenberg talk about telemedicine. That is, I think, going to be very, very important in the future, being able to communicate with doctors and patients at a distance. But what they asked us to do was look at telesurgery, where we can operate at a distance. So, for example, a patient in Rwanda has a problem. I'm in Orlando, and using the internet and computers, we can connect directly to the robot here in Rwanda and operate it from Rwanda. Those are the things that we need to do. especially for the humanitarian benefits, because in areas where there may not be surgeons who have the skill or they get in trouble, it'd be nice to be able to call an expert right on the spot from anywhere in the world, and they can operate on site. So I'll show you some of the more futuristic things that are coming. Telesurgery has already been performed. It's called the Lindbergh operation, and it was performed between France and New York. Basically, they shut down French telecom, and a surgeon in New York operated across the Atlantic, and the patient was in Strasbourg, France. It was just a cholecystectomy. It was a very basic operation, but it was the beginning of telesurgery. So one day we'll be able to operate at a distance. Today, it's still not possible. And the reason is too much time delay. If I make a movement, it has to go over from here, from Orlando to here, and then it has to come back. Our jobs in the grant is to see if we can shrink time to make these transmission of these signals faster so we don't see the time delay. And you see, they're able to do it, but it's very difficult for them to do this type of telesurgery. This is something that the U.S. military does, and this is actually existing equipment. This is what they want to do. They want to have soldiers in the field, but they don't want the surgeons to be there in the field of battle. And so what they're looking at is doing everything automated. The soldier gets shot here, a signal goes off to a helicopter that comes down, and all of this is automated. All of this technology actually already exists, and this is their goal, is to be able to automate everything so a soldier that's hurt on the battlefield can now be stabilized right on the battlefield, because most of them who die right then. Here, the soldier's been shot. You can see there's a bullet in the femur, and they're basically going to remove the bullet. So they make an incision here. Even the medication can be given using a robot. All of this technology exists. They're just at the point of trying to put everything together so that automatically the robot can do the x-ray, sense where the bullet is, remove it, and stabilize the patient and airlift them out. So all of this is automated. And this is, I think, has great benefit and potentially has life-saving potential here. So this is some of the things that we're working on. Other things that you'll see in this future is more simulated surgery. Simulated surgery is where you practice surgery before doing it on a hologram, or you're doing the surgery on a virtual model while the robot's doing it on the real person. And this is a look into the future. The patient is actually in another room, and at this time with the robot, and you'll see it here on the right side in a second. The surgeon is at a console. Basically, the patient has had a 3D scan, and all of their organs have been scanned. And you see that's where the patient is over to the right there in another room. Here, the entire patient's been scanned, and the surgeon is operating virtually on a hologram. Why is that better? Because you can take away all the other stuff you don't want. You can take away the blood, you can make the organs larger. It's easier to operate, obviously, on a virtual image than actually on a real patient, where there's blood issues, there's space issues, and there's issues of organ size. So even here, even the robot has become a holographic image. So this is an operation. This is how many decades down, there's the heart. You see the surgeon enlarges the heart, sets it up so I can see it. And that's the delay. So there's about a 200 millisecond delay per satellite bounce. So the time delay makes these surgeries too difficult. If I can't see my movement for a half a second later, it really throws off the rhythm. Plus the patient's moving. So you obviously cannot do telesurgery yet. This is what we'll be doing. So here's some recent events. There's an operation here. There's two robots. There's one in Seattle, Washington, and there's one in California. And these two surgeons, who I know very well, are actually practicing. They're trying to give each other these little yellow and blue tubes. It's harder than it seems, because the surgeon moves his hand, but he doesn't see the instrument move probably until about half a second later. And so to coordinate, even handing off these tubes is very difficult. So imagine if you're doing a real surgery with blood, the patient's heart's beating, the organs are moving. Very, very difficult to do. So our one sets it up. There's an issue with the heart, and then the robot will come in and do the operation on the real patient. So as you can see here, this is kind of the things that we're thinking of. This is where it's going, and it's definitely going to be easier operating on a virtual image, and then you practice, you find the one that works right, and then the robot does it perfectly. So these are all things that we want to look at. Operating rooms of the future will be necessary. This is how, right now, I sit down at a console. You saw the console that I sit at. This is probably the way it will go. We'll wear a headset with a screen. We'll sit down, and basically the robotic instruments will be controlled with our eyes, our hands, and our feet. And all of the x-rays and all of the images of the patient will be right in front of us. I think this is not so far away. We're already doing things like this, but I think probably another 5 to 10 years, and we'll have the technology to be truly able to do all of this remotely. So these are some of the looks into the future, and probably what I'll do is I'll talk about kidney surgery next, and then I'll take some questions after that. But I wanted to show you some of the things that are coming in the future as you build your healthcare system here, because obviously there will be a lot of growth in the healthcare system in Angola over the next decade. Let me switch presentations. So going from virtual surgery back to real-time surgery, kidney surgery and prostate surgery are what I usually do, really cancer, whereas robotic surgery has really taken over prostate surgery. And kidney surgery it's taken a little longer, and the reason is we were already doing it laparoscopically. But I would say now that those that have robots pretty much are doing everything robotically, and these are all the operations that we can do. In the early 2000s, we really didn't know if robotic kidney surgery would work. I would say 10 years later, it's going to be the standard for us in the U.S. just because it's easier to do. It's easier to see, it's easier to manipulate the instruments, and definitely easier for the patient. So I'll go through various disease types and how we treat them. Here's a patient with an obstructed kidney. You can see the hydronephrosis of the kidney, and basically the patient has a ureter that's kinked. And the reason the ureter is kinked is because of the fact that there's an artery and a vein that are congenitally in the wrong place. And so our job is to go in and actually remove the obstruction, cut the ureter, let the artery go back in its normal place, and then sew everything back together. So this is how they're positioned, this is how the ports are placed, and the robot comes in on the side of where the obstruction is. So here's some video. So these are two robotic instruments, as you can see. Much nicer than we would see open. We see very, very good anatomy. The white structure there is the ureter. It's the tube that you saw in the x-ray. And you can see what I'm pointing to is the arteries and veins that are crossing over the top of the obstruction, and they're blocking. And so our goal is to transpose the ureter and the renal pelvis over the blockage and then sew everything back together. This used to be very challenging with open surgery because it was hard to see, but it was even more challenging laparoscopically because it was very hard to sew. So robotically, you have the best of both worlds. You can definitely see much better, and you can definitely sew much better. So the blue thing is a stent. It's a tube that's been put in there to bypass the obstruction. But here we're going to sew everything back together. So what you see is the artery and the vein that were blocking the kidney have been transposed posteriorly, and now we'll go ahead and sew the kidney back together anterior to them, and the obstruction is gone. So I think this is an operation that we did open. We did it laparoscopically. It was a little bit challenging, but it could be done. The robot just makes this easier. It's a 30, 45-minute operation on most patients, and they go home the next day. And so life is much easier, I think, doing it this way. And you can see here, the suture we're using is very fine, and we're able to sew everything back together and tie the kidney back together. So this is pyeloplastic, one of the things. How these patients do, we published on this. We did a multi-institutional study looking at how these patients do, and what we found was that the overall success rate was very good. About 96-97% of patients have improvement in their function in terms of their excretion, and overall, patients don't get worse. kidney usually does not get much better, but the key is not to have it get any worse. And so we found that this is an effective operation, and I think it allows more surgeons to do it. The suturing is much easier, the vision is much better, and therefore pyeloplasty done laparoscopically with a robot is much more common than just pure pyeloplasty because it's more easier for surgeons. Other things that we do, we also take kidneys out robotically these days, and the advantage there once again is vision. We turn the patients on the side, and then the robot comes in and we put the ports. Just like we saw when we showed the video of the robot, you have these little areas where we put tubes into the abdomen, the instruments go through the tubes, and then we operate inside of the patient. So this patient's his head is up there on the left-hand side, his feet are on the right. We're measuring exactly where those tubes need to go. We place the tubes in, and then we bring the robot in. And so how these tubes are placed are very important, so the instruments can all work in their own area without crossing or clashing. And so this is how the robot comes in for kidney surgery. And you saw earlier how we were clamping the robot to these tubes. So here's a little video. It's one of the nephrectomy, as we're calling it, where we take out part of the kidney. It's a partial nephrectomy. So you can see here with the robot, you have very good vision. You're able to dissect things very cleanly and do it very precisely. And the small little scissors, it's about this half a centimeter in size. We're able to dissect everything clearly, lift everything up, and then take out the kidney tumor. So this gentleman has about a 4-centimeter tumor. That's his vena cava there, that big structure at the bottom of the screen. There's the renal artery. As you can see robotically, even these structures like the renal artery look quite large, and they're much easier to dissect than it was when we did them open or even laparoscopically. There's the renal vein. I think what you notice the most is relatively minimal blood loss and a lot of control. So I think that's the biggest advantage here at the renal hillock is we're really able to control the dissection using these robotic instruments, and we're able to see everything so we don't cause a lot of bleeding. So as you can see, very large vascular structures we're working with there, and we'll go ahead and clamp them and dissect. So this is where the kidney tumor is. It's covered by a lot of fat. We place clamps on the arteries and on the vein. These are clamps, and the reason is before we cut the kidney tumor off the kidney, we obviously have to stop the blood flow. If we cut the kidney and we haven't stopped the blood flow, there's going to be a lot of bleeding. So here we're clamping the artery, we're clamping the vein, and then you'll see us excise the tumor and then sew everything back together. So there's the tumor. It's being excised off the kidney with the scissors. You see us cutting it. Once this is excised, then we bring in the sutures and we start to sew everything back together. Obviously, you have to sew the arteries back closed before we let the clamps off. So here we'll sew. We'll put this white stuff on there. This white stuff is called flow seal. It prevents bleeding. And then we'll go ahead and suture the kidney back together. And here you'll start to see the end. So we put hemostatic agents. This white tissue here is basically something that stops bleeding. And we're pushing on the kidney to provide compression so that all the arterial blood supply is compressed and it doesn't bleed. There you see we have little clips, squish everything together, make sure there's no more bleeding, and then at the end you see there's no more bleeding. So about a third of the kidney was removed there, but you see very, very little blood, and once you remove it, you take the clamps off. So once again, the experience is very good with partial nephrectomy. This is the largest series, about 183 patients. It's been a little bit over 2 hours, 2 to 3 hours, but you see the blood loss is quite little, and the patients do very well. So cutting into the kidney used to be very, very difficult doing it laparoscopically. Robotically, it's much more common, and it looks like this is how things are going to go. Most times these days, we don't have to take out the patient's whole kidney if they have cancer. That was more of a thing of the past. Most of the time, even if they have kidney cancer, we can just take part of the kidney, and it's due to technology like robotics, because we have much more control. Other things that we can do, Here is a patient that has a big diverticulum on the bladder. This guy came to us after many, many years of having problems urinating, and we got some x-rays, and basically we found that he had a very large obstruction on his bladder and his prostate. So the prostate was blocking the bladder, and he formed a big extra bladder really behind the trigone. And we'll see an x-ray here in a second of what we're exactly seeing. So you see now, this patient looks like he's got two bladders. The one on the back is not the real one. So the small one is the real bladder, and the other thing posteriorly there at the bottom of the screen is extra. It's a very large structure. And so robotically we're going to remove this and then sew the hole between the two and close it. So these are things that we can do which were very, very difficult to do when we did open surgery or laparoscopic. So here we're just dissecting out the diverticulum. We also have a camera inside the bladder to show us exactly where to cut. So it's really a combined procedure, using endoscopy in the bladder and using laparoscopy and robotics through the abdomen. So there's that extra bladder, the one that we want to remove. We just dissect it out with the robot. And you see, it's relatively straightforward. It doesn't move like a robot, it really moves like their own hands. And that's the big advantage. So this is one of the things that we can do. See how it ends up. Sew it up, and that's the final structure at the end. So these are one of the things that we do. And one last video that we'll show is removal of the bladder. So we showed prostate cancer, we showed kidney cancer, and this last video is on bladder cancer. This is a patient that has bladder cancer, and we're going ahead and removing his bladder and then recreating a new one. And so removing the bladder is one of those things that is not an easy procedure, but I think robotically it's relatively easy. It takes about an hour to two, depending on the severity of the cancer. But as you can see, even though the organ is quite difficult to get to, with the robot and the magnification, you can see things very well. So what's interesting is, in the African continent really especially, there's no robots yet. So in the United States, probably we have about 2,000 robots. In Europe, they probably have about 500 robots, and none in Africa yet. So it'll be interesting to see where the first robot comes to Africa. And I really think it should. I think it's much easier for patients. They go home the next day, they feel better. We don't even send them home with narcotics anymore. So for quality of life for these patients, it's much nicer. And so it'll be interesting to see and nice to see robotics come to the African continent. Once again, it's always a pleasure and an honor to be here. Thank you to the organizers for inviting me. Thank you.